Hi, I'm Jessica Rial, and I am here today with Susan Clinton from Pittsburgh, Pennsylvania. So, for those of you who have followed my blog for a while, you know that I love talking about bowel dysfunction. It's one of my favorite diagnoses to treat. One of my patients used to say that bowel dysfunction, it's one of those things that you kind of take for granted your bowels functioning normally until suddenly they're not working.
Hmm.
And we hear that all the time in the clinic. And so I wanted to take some time today to highlight a really unique treatment for bowel dysfunction, and that's called sensory balloon retraining. And I'm so fortunate that Susan agreed to talk with me today about this. She is a pelvic physical therapist, and she is well known in our field as being one of our bowel gurus. So I'm going to go ahead and let Susan introduce herself to you today. Thanks for joining me, Susan.
Hi, Jessica. I'm Susan Clinton. I have a private practice outside of Pittsburgh in the suburbs near the airport. And I have been probably treating patients with these diagnoses for about 25, 30 years and have grown and changed with the field. In the beginning, we didn't really have a whole lot that we could understand about it. The world of GI and bowel changes, and certainly with all the issues that we're learning now about diet, GMOs and glycosates in foods and all kinds of gut disturbances, we're beginning to learn how very important bowel function is for the health and wealth of the patient.
Yeah, for everyone.
So anybody out there that's kind of has experienced, a bad day with their bowels knows that it kind of takes over your whole world. So oftentimes when you have bad periods of time with your bowels, it can really, really be kind of a life changer and in many people kind of a sideliner. It kind of takes them to the side and they're unable to participate in their life in much the way that they want to. So subject near and dear to my heart as well.
Absolutely. I think it tends to impact so many people. And the hard thing with that, as well as many of the things that we treat, is that it tends to be one of those diagnoses that are very private, that are embarrassing, that people don't want to
Hmm.
share with their friends. And so people end up coming to Google and searching to try to find support, to try to find help, because it tends to be a private thing people suffer with alone. So
Right.
yeah, so let's jump in first. Let's talk about what exactly is balloon retraining, because when I mention it to my patients, I get the look like, wait, what are you wanting to do? And most of the colleagues who I have in this area and other areas as well, it tends to be a treatment that it takes some special skill and knowledge in order to perform. So would you mind talking a little bit about that?
Sure. I don't think that the knowledge is that special. I think it's because we're just not used to thinking about, putting a balloon into somebody's rectum.
That's very
And I
true.
think that's probably where people start to freak out.
Yeah.
But I've got a picture, I've got the balloon here. If everybody can see it, you want me to show it?
Yeah, would you mind just pulling your camera down just
Sure.
a little bit so we
Be
can,
happy to.
there we go. You're perfect.
So this is the balloon here. You can see the straw. It goes right up into the balloon. And then down here at the end, we have just a little area that we hook a syringe to. And this is what we fill the balloon with, the air. So it just hooks right onto the end. And so we can put air into the balloon and take air out of the balloon. One of the things that I think is important to understand when we think about, before we can even talk about balloon treatment, is getting people over the fear of the balloon.
Yes.
And so one of the things that I'll do is I'll point out to people that if you see when I crunch up the balloon here like this, you can see when I put it dead onto the camera how very little it is. So it's just a rubber balloon around a straw, which happens to be about 1/3 of the size of my finger.
Mhm.
So if you're having PT for bowel dysfunction, somebody's done an intrarectal exam and an intraanal exam. You've had that done. You know what it feels like, and you know what the finger feels like. The very cool thing about this is that this is way smaller than my finger. So this is not to be afraid of at all. And then everybody kind of freaks out about the balloon. Well, what we do is we put a condom over it. So if the balloon, for whatever reason, which it never does, tends to either fail or maybe unattach from the straw, which would be like, just a once in a million event, but it would just be housed inside the condom. So it's all like super, uber safe and easy to do. And again, so much more gentle and comfortable than having your finger running around in there trying to do all of these different things. So
Absolutely.
kind of with that said, that really helps with the balloon quite a bit, because we're able to really kind of make things, um, get the patient, and decide that, all right, there's only so much we can do around the muscle shelf. And the muscle shelf is what when I talk about that, for people who don't understand what that means, is the area of your anus where you actually open up to expel the stool. We have a great deal of sensation in that area. And anyone who's had an anal exam understands that. It can be painful, it can be sensitive. None of us like it. I don't like having it done, but I have to go and get colonoscopies and things as well, just like everyone else. But the beauty of working with sensory training is when we have people who have had constipation for a long time, or so they don't feel when they need to go to the bathroom as much, or on the flip side, when we have people who have urgency, like it feels like I always have to go, even though I don't. I just went to the bathroom and it still feels like I have to go. I have to go. So we can have both ends of the spectrum go a little bit crazy for us. The coolest thing about doing this is that the balloon really helps us retrain that sensory perception. And what I mean by that is it's not really what's going on at the muscle itself, but it's what's happening in the pressure system above the muscle. So the rectum is a vessel that basically is collapsed unless it's filled with something, and it responds to pressure. There's no sensors in the rectum that will respond to what we would consider a painful stimuli. It doesn't have those kinds of receptors. It only has pressure receptors in there. And that's what makes the balloon work, because the balloon blows up or shrinks down like a stool would as it enters the rectum. When the stool enters the rectum, it fires off the pressure receptors, and we can get pressure change feelings all throughout our whole body, up into our esophagus, down into our stomach, and maybe even into the lower pelvis or in the back of the rectum, where we might feel, that pressure. And that brings on maybe the cramping or that kind of experience, like, oh, something's there, I need to go. When we start getting into more of the sensations around the muscle, that means that the stool has come down and now has engaged with the anus and the muscle wall, the muscle shelf there. So we get two different kinds of situations going on. The nice thing about the balloon is we can insert it well past, so that we can insert it well past the anus up into the rectum, and then we can keep everything super still. And all they're going to be worrying about then is just sensing, do I feel something in my rectum? Do I feel that pressure, or do I not? And in that way, we can help them begin to understand that, oh, so if they have had constipation for a long time and they don't have a lot of good sensation, we can blow the balloon up, and they might for the first time begin to understand that I don't feel anything in my rectum, but you know what? I feel pressure in my abdomen. And that could be them to signal, this is how I know I need to go to the bathroom. Maybe I don't have to wait until it's that big rectal pressure. Sometimes minor rectal pressure in somebody who has lost sensation can signal pressure systems, signals somewhere else in the body. And it helps them kind of get in tune to what's going on. On the flip side, if they're really hypersensitive, super sensitive, we can actually, what we call in physical therapy, and I'm sure you've talked about it on some of your other blogs, is downtrain, or desensitize the system. So we can just blow it up just a little bitty bit. And they can say, oh, I really feel that a whole lot. It's like, okay, breathe through it. See if you can change that experience. Let's bring the air down out of it again. And then we can keep kind of working. So it's almost like just kind of nudging up against the really sensitive system and getting it to kind of go, oh, that's not so bad. That's not so bad. That's not so bad. And, the nice thing about the balloon is that it's the only modality that I know of that we can actually work on this system.
Yeah. Yeah, I think balloon retraining is awesome for that. And I see it's interesting in the clinic, you see both sides. I find for the patient who is really hypersensitive that in some way the balloon can be a really reassuring thing. That,
Mm-hmm.
oh, wow, I'm feeling this overwhelming urge to have a bowel movement when there's really not much stool present in my rectum.
Mm-hmm.
And that knowledge alone can be so powerful that, hey, I can learn to defer that sensation. And instead of going to the bathroom 12 times in the morning, I might be able to slowly get that down to going less frequently, but actually emptying a larger volume. But on the other hand,
Exactly.
the patient who has this over distended rectum too, like you said, can be so powerful to be able to recognize what different sensations are they're feeling and be able to start retraining the ability to feel a normal urge.
Right, right.
Can you talk through, if I'm coming in and I'm a patient who is having constipation or fecal incontinence or urgency bowel dysfunction, what exactly is this procedure going to look like? What am I going to experience on the table?
So basically what we're going to do is I never put anything into anybody's body until I've done my own exam.
Mm-hmm.
So, and for all of you who have come in, this would not be day one. It would not be day one. Day one would be, our evaluation, what's happening with your pelvic floor muscles, what's happening with your hip and your back, and, all of those different things that we look at. And then we start, kind of getting an idea of when your bowel movements are coming. Are you a sensitive, kind of hypersensitive type situation? Or are you a hyposensitive? And so then, we just make a plan. And if the ballooning is part of the plan, then, we know what's going on that day. So they come in, they get ready, they, off with the lowers and cover with the sheet. I usually do the very first couple of times I work on this, I do this with them in sidelines so they can just get comfortable. It's an idea of just kind of being able to be really quiet so you can just be able to hone into the system. If we have a whole bunch of stuff going on around it, it's distracting. So we want to kind of just like be nice, be quiet, be easy. And I do a bit of a rectal exam, to know which direction, what's happening. Do they have a hemorrhoid that's bleeding? I may not want to do balloons that day. Do they have a rectum that has a large amount of stool in it? That probably wouldn't be a good day to do the balloon. We'd want to evacuate first and then maybe do the balloon training. But basically then we just, I just talk them through it. We slide a condom over the balloon, put some lube on, and, and I show them the balloon and I show them what the balloon looks like when it gets filled up with air and what it looks like when it's deflated, so that they really go to and let them, feel it, touch it, play with it, because I think there's a lot of power in knowledge. And then, so what we do is we just go ahead and I'll tell them that the sensation you're going to feel is the straw sliding past that muscle shelf where you have great deal of sensitivity. So you're going to feel that, but once we get it in place, we're not going to be moving it around. So so they feel that, they know it's coming. We slide it in. Again, I remind them it's much smaller than my finger, which has just previously been there. Mm-hmm. Get the balloon in place, and then I just, we just kind of talk a little bit and relax. And then I hook up the syringe and I'll just tell them that we're going to go ahead and start putting some air in the balloon. I want you to tell me when you feel anything that feels like pressure at all. Or does it feel like your symptoms if it's somebody who's really, hypersensitive or painful? And just let me know if this feels like your symptoms. So I'm really careful to keep the balloon still, because if I wiggle it, it's going to, fire off all the receptors around the muscle shelf. It's going to be a false positive or a false feedback. So, and then they tell me when they first begin to sense it, they're okay with that. If they can actually, sometimes they can just be quiet and breathe with it, and it makes the sensation go down, so we can add a little more air and begin to start changing their really hypersensitivity if that's what we're working on. Or if there's somebody who's very hyposensitive, then we may have to go to bigger volumes. The balloon can hold up to 300 volumes of air, which can make it quite big. There are times when people may need to sense that in the beginning just to get some sort of sensation. But I have found that even people who are very hyposensitive, if I get them to somewhere between 180 and 200, they're generally getting a signal somewhere else in their body. Generally it's more of an abdominal cramping that begins to occur. And for the first time, they begin to associate that with, there may actually be stool there. And this is the sensation I'm getting because for whatever reason in my lifetime, I quit listening to the signal to go. Maybe they were a school teacher and they couldn't go to the bathroom when they wanted to, or a busy mom who just was like, never had time to go to the bathroom, or, just depending upon, there's so many reasons why we may have like extinguished that signal to go. And we need to help just kind of reignite that again, get that mind-body connection going. The
That's
final thing that we do is we work on expelling the balloon, because whether they are hypersensitive and painful or constipated, they all have difficulty coordinating, having a bowel movement. And this is the only modality that allows us to help them understand and feel the sensory experience the way it really should be. So if they're a constant strainer, they may be overstraining and kind of shutting things down to where the muscles just tighten up so much it just won't work. Or they may be somebody who's so painful they can't really generate some good forces, and then they've lost the coordination or the ability to move the stool through. So I'll shrink it down to about 10 or 20 milliliters, which isn't large, but it gives them the idea, and I'll help them. And what they'll experience is the experience they have is that I'm actually going to have a bowel movement on the table.
and that's their biggest fear going into
Absolutely.
the
And we've all done it together because we had to learn, on ourselves, so I can kind of calm them down with that. It's like you are, but the bowel movement that you're having is the balloon coming out. And that's what it should feel like. So we can work them into, just so that they get that sensory feeling again. And oftentimes, 1 or 2 times with that sensory experience is enough to help their brain go, I know what to do now. For people who are having a lot of trouble, with that sensory experience or being able to expel stool, I can, in, a couple of treatments later, work them into a sitting up position. And they can actually expel the stool over, we have a bedside commode that looks just like a toilet, and a big bucket, and all they're going to be doing is dropping the balloon in there, but I can help them with the straw, so that they can get the feeling in more of a sitting up type position and posture. So we can make this very, very functional for them as well.
That's awesome. That's awesome. Now, you mentioned briefly one of the biggest fears that patients have, I have seen clinically going into this treatment is, oh my gosh, I am going to poop in front of you. Well,
right.
I tell them I have never seen that clinically happen.
Mm-hmm.
And even though they feel like it's not going to happen, is that a sentiment you would agree with clinically?
Right. They all say that, and they all have a fear of it. And so one of the things that I'll do is I'll reassure them that we have adequate padding and the pads on the table, the chuck pads, which are those blue pads that that are absorbent. They're unabsorbent on one side and very absorbent on the other, that if by any chance something like that was to happen, we can get it cleaned up right away. And it's not a problem. Right. Because one of the things that we want to have happen, right? We really want them to be able to do this. But yes, it is a big fear. We're just not, our society is kind of closed off about, urinating and defecating. We just really are. There's a lot of people who have a fear of doing it in a public restroom. They just, even the thought that somebody might be in the same room with them behind closed doors and everything, being the same. And I totally get that. Everybody's experience is a little bit different. So we just want to kind of respect that as much as possible, which is why I like it to be kind of quiet on their side, so that there isn't a whole lot of people like banging on the door and knocking. It just needs to be a nice, quiet environment so that they can pay attention to those signals and feel safe that this is going to happen. There's a wonderful radiology interventionist, which means that, for those of you who don't know what that means, somebody who actually looks at real-time motion under imaging. So he does functional MRIs. So he actually puts things into people's rectums and have them poop it out, much like a depicography or some of those other tests that maybe some of you all have had. But he does it under an MRI so he can see what happens to their pelvic floor. Do they have a rectocele or part of their rectum, kind of flopping forward into the vagina? Do they have hemorrhoids? He looks at all of that. And one of the things he talks about, the biggest problem he has with people, because he says most everything looks like that they have like a pelvic floor muscle problem. And he goes, and it's not, it's fear. They don't want to poop on the radiology table, so this is everywhere. It's not just in the physical therapy clinic. And so it kind of also makes me wonder just a little bit sometimes about, a little bit of false GI radiology readings sometimes, because, it's something that we have to overcome when we're doing testing. And it's hard as the patient to overcome that, because you just can't help how you feel in your body. And so that's why this is never kind of a one-time thing.
Yeah.
It's usually a, let's get started, let you get the feel of it, get them to feel the experience and be comfortable and confident with it. And then it makes it so much easier to go through and actually train. When they go to the doc's office, to have testing done, they get one shot at it and that's it. With us, we can really make it a lot more comfortable and then really make it a lot more functional so that they really get the hang of, this is no different than what I would be doing at home. Put your feet up on the stool, let's do this. We can kind of simulate all the different things, and it just really helps them with that internal sensory experience that they wouldn't have any other way.
Yeah, yeah, that's awesome. I mean, I agree with everything that you just said. I think with bowel tests, but with bladder tests too, we see the same thing, that
Mm-hmm.
it's how do you go in and pee while there's like a nurse staring at you and expect it
Right.
exactly the way you pee at home. It's a challenge with testing, but
It is.
you're right that, and I think as pelvic PTs, we also have the benefit that we are building these relationships with our patients. And so by the time we get to the point where we're doing this treatment, we should have this trusting clinical relationship where we have this honor, I think, of being this person that they
Mm-hmm.
can feel open with to talk
Mm-hmm.
about these issues that are so private, and there's so much
Mm-hmm.
fear. And especially once people start leaking stool, or on the other hand, for the people who aren't able to have bowel movements regularly.
Right.
So it's a big
Right.
honor that we can come in and
Mm-hmm.
play that role for them.
Mm-hmm.
So what would you recommend then if, well, let's go the clinician route, because we do have many different pelvic PTs who follow this and will be watching this. And if
Mm-hmm.
I am a pelvic PT watching this, and this is not a treatment I do because that balloon is scary, what's your recommendation for how I should start going about helping my patients this way?
So my recommendation for clinicians is to get together with another pelvic health clinician. This is how I learned it.
How I learned
I
to.
I picked up the balloon and I got with another PT, and we figured it out. We knew how to do rectal exams. We were experienced at it. So we basically got together, and one of us would put it into the other person, and we learned that you have to insert it past where the balloon is. You've got to come down at least, I usually tell people they need to come down at least 2 inches. You really need to get the entire balloon up into the rectal cavity. Unless, of course, you're working on muscle function, then you can fill up the balloon and pull it down against the muscle shelf so that they have something to kind of hold up against. That's a whole nother piece. But for sensory training, you got to get this balloon up into the rectal cavity, and then you got to figure out how to keep it still. The rest of it it's all mechanical. It's how do you do this with the syringe, hold this still, learn where the off and on switch is, and keep the balloon still. And so my recommendation is practice the balloon a lot before you ever put it in somebody's body.
Yeah, I
So
totally.
that, because it's it's the neuromuscular control. That's the wall to get over. The other piece is easy. You're a PT. Okay, desensitization. I'm not going to put very much air in. We're going to gauge. We're going to see if we can do a little more and a little more and a little more. If it's hyposensitive, I need to get it up there to where they're feeling something somewhere, and then begin to back it down so that they get that sensation earlier. And if you want to practice with, muscle control and, being able to hold against a stool that may have come down, but you're not convenient to go, put the balloon at 30 or 40 milliliters, bring it down to the muscle shelf and have them work against it. Here comes the balloon. They feel it. Okay, tighten up and pull back against it. So you can turn it into a nice neuromuscular reeducation control thing as well.
Awesome.
I've even had people use the balloons for gently beginning to change a vaginal canal or a rectal canal that may have stenosis from chemotherapy and radiation.
Oh, that's awesome. That's awesome.
So they may be completely asensitive, but you can do some easy stretching because it's circumferential. It's a balloon blowing up, so instead of just pushing on one end of the canal, on the tissues, the balloon can actually begin to kind of just open and stretch the whole vault. And you could do that in the vaginal area as well as the rectal vault,
Yeah,
which is kind of cool.
And now this is just me thinking now as you're saying that. I wonder if it's been used helping women in preparing for childbirth at all.
I can't see why it wouldn't hurt, in conjunction with a perineal massage,
Yeah,
to ready the tissues. It would make a lot of sense to me.
yeah, totally.
And for people who don't have the ability to this is an old Ashley 2 catheter that they don't make anymore. I just use it for demo purposes now, because they can't get them in this country anymore. The ones that they can get aren't quite as oblong. They tend to blow up a little bit more circumferentially, like rounder instead of, oblong like. Um, I mean, that's what we have right now. And I know that they're trying to get some other ones in. There's been a lot of talk, about using the balloon with or without the catheter. I had the privilege of talking to the manufacturer, one of their tech people, who said, why are you putting, because somebody had trouble with the balloon ripping, and they decided that it was because of the condom, and they said, why are you doing that? And I said, why would I not? They go, well, they're designed for one use only, and the balloon shouldn't come off. And I said, well, what if it does? Well, then you just wait for them to poop it out. Well, now you and I just talked about how, can you imagine
Terrifying for the patient.
that people are already upset about having a balloon in, and then I have to go and tell them that there's a possibility it could break, and you didn't just have to wait for you to
Not a balloon.
no, it's like, no, the condom makes it so the condom's always sticking out. So it's so easy that if anything happens at all, it's easy to deflate the balloon down to nothing, first of all, so that whatever might be helping somebody, they're having a hard time with, you can get it right down to zero and everything's fine. And then all you do is grab hold of that condom and slide it all out, and everything comes out together, and it's so nice.
Yeah. Yeah.
It's just a lovely way to do it. I couldn't imagine doing this without condoms.
Yeah. When I first started, we didn't, because I didn't know, like
Right.
when I first started
We all learned.
I taught myself. And it's funny because I can actually, and one of my colleagues who may even watch this at some point remembers when we were first practicing the first time she did it and that balloon came out. She still makes fun of me because the look on my face was, oh my gosh, I just pooped on the table.
Yep.
And, you feel that. And it's great because I can give my patients that feedback now too. But we started using condoms as well. Just as I think there's that protective for that patient, knowing that that balloon is nice and secure. Although I've never had a balloon break or rupture.
So the best condoms to use are the non-latex, and if you can get them without the silicone lube. They don't make non-latex, non-lubricated condoms. They just don't. I've looked, but you can get the non-latex, non-silicone lubricated balloons, and that tends to preserve the life of the balloon just a little bit better.
Excellent.
So.
Before we wrap up, do you have any advice if I'm this patient watching this right now and I'm sitting there going, oh my gosh, this might be me, I might need this. What advice do you have for me as a patient?
What advice do I have for you as a patient?
Yeah.
Ask lots of questions to your physician, and make sure that they send you to a really good pelvic health physical therapist. And when they do, ask them if they do the balloon training. Ask them. And, if they don't, and you feel like it's something that you need, then ask them to see if they can refer you to somebody, to have it. I think most of us understand it and know it. And there may be a lot of other things that we're going to be doing in conjunction with this. So, some of that stuff, like I said, this isn't the first thing I do first day with somebody. It's always after we've kind of, come up with a list and we've got the, the plan, and this is part of the plan. So if you feel like it's something that you need, you can certainly get in touch with Jessica or myself, and we'll be happy to help refer you around if you don't have anybody that you're working with. But the best advice is to ask questions.
Excellent. Awesome. Well, so for those of you clinicians who are watching, if you're not familiar, Susan actually teaches a great bowel course and teaches a lot, which is awesome. I've had the pleasure of listening to Susan teach previously. Do you want to talk a little bit about any upcoming courses or anything that you have?
Sure. I have there's two courses that I generally teach most of the time. One of them is a GI dysfunction course, in which we talk about the balloon catheter and as part of the course. I can also do online mentoring, like over a medium like we're doing here with Zoom, so people don't have to travel. And I can teach people to do the mechanics, and we can do an hour or two of clinical reasoning around complex patients with the balloons. So that option is always available, and you can find me on my website, or Susan at embodied-pt.com will always get you to me. And I also teach a course on changing the pressures and the connections above the diaphragm to the pelvic floor. So we get into all of the upper cervical, neck, throat, voice, breathing in some different ways, and manual therapy of the upper quarter, and how that can have great profound effects on the GI system and the pelvic floor.
Awesome. Awesome. Well, thank you so much for chatting with me today, Susan. I hope all of you enjoyed this and benefited from it as much as I did. Please feel free to stay tuned in the future for more expert interviews on lots of different topics related to pelvic health. And stay tuned to my blog, jessicarealpt.com, for additional blogs and information. I will go ahead and put links both to Susan's clinic as well as her upcoming courses, as well as some more information about bowel dysfunction that we have on the blog, so that you can look there for more information. But thank you so much for joining me.
Mm-hmm.
Great.
My pleasure.